I am Dr. Charles Faiman, the chair of the virtual Grand Rounds sessions on type 2 diabetes. I am a former chairman of the Department of Endocrinology, Diabetes, and Metabolism at the Cleveland Clinic and currently a consultant in the department. I am pleased to welcome you to this third lecture in our fourth season of CME-approved presentations dealing with type 2 diabetes, an educational program sponsored by the Cleveland Clinic. Once again, we will follow a case-based format. There is a growing worldwide problem of diabetes and prediabetes. The CDC's National Center for Disease Statistics estimates that 29.3 million individuals in the U.S. have diabetes, and a staggering 86 million have prediabetes. The majority in the prediabetes group are unaware of the diagnosis and its accompanying cardiovascular risks. Today's presentation on prediabetes is aimed to provide insight into management strategies. That is to say, the rationale for early diagnosis and intervention in order to prevent or delay the progression to frank diabetes. It is my pleasure to welcome our speaker today, George Grunberger, MD. Dr. Grunberger is the founder and chairman of the Grunberger Diabetes Institute, a patient management and research facility. He is clinical professor of internal medicine and molecular medicine and genetics at Wayne State University School of Medicine in Detroit, Michigan. He is recognized nationally and internationally as an accomplished clinical investigator and a well-respected and sought-after lecturer. He is currently the president-elect of AACE, the American Society of Clinical Endocrinologists. Dr. Grunberger.
Well, thank you, Dr. Faiman, for that introduction, and I'd like to welcome everyone to this hopefully interesting discussion on a topic of prediabetes, making a diagnosis and selecting a treatment approach. I'm George Grunberger. I'm chairman of the Grunberger Diabetes Institute in Bloomfield Hills, Michigan, and I'll be your guide over the next 30 minutes or so. As we know, epidemiology of prediabetes is getting overwhelming. About 86 million people have been estimated to have prediabetes just in the United States, and total cost of diabetes in 2012 in the U.S. was $245 billion. And unfortunately, with that many people with diagnosis of prediabetes, that cost will probably be going up significantly unless we do something about it. So the purpose of this program is to see whether we can do something about preventing diabetes in high-risk individuals. In the 2005-2006 NHANES survey, about 30% of adults had prediabetes, but most of those had no idea that they were so afflicted. So for physicians, it's always about a patient. So let's talk about a patient. We have a 55-year-old woman who presents for routine examination. She's been complaining of persistent fatigue, and she did admit that she was diagnosed with gestational diabetes during both of her pregnancies, and she has a strong family history of type 2 diabetes with both her mother and aunt having it. She's 5'5". She is 205 pounds, so she is officially obese with a BMI of 34.1 kilograms per meter squared. Her fasting plasma glucose is 110 milligrams per deciliter. So the question is, in this woman, does she have prediabetes? Does she meet those diagnostic criteria? For those of you who don't remember what the diagnostic criteria for prediabetes are, this figure shows it. Clearly, this lady qualifies. Whether you look at the American Diabetes Association or the American Association of Clinical Endocrinologists criteria, they're pretty much the same. It's fasting plasma glucose above 100 in the 100 to 125 milligram range, or impaired glucose tolerance if someone has an oral glucose tolerance test and 2-hour value after 75 grams of oral glucose is between 140 to 199 milligrams per deciliter, they have prediabetes. Somebody can have both, impaired fasting glucose and impaired glucose tolerance. Hemoglobin A1C levels between 5.7 to 6.4 have also been mentioned as criteria for prediabetes. And AACE also has additional criteria, that is, if you have metabolic syndrome. So any or all of those will meet the diagnostic criteria, and Our Lady in question with her elevated fasting glucose, 110, already qualifies. So when we talk about screening high-risk individuals for prediabetes, because as you saw from the NHANES figure, very few people actually realize they have a problem. It's the usual list of the suspects, where we mention family history of diabetes, personal history of cardiovascular disease, being overweight or obese, and sedentary lifestyle. And you can see the rest of that on the slide, including the markers for metabolic syndrome, such as hypertension, the classic dyslipidemia of insulin resistance with increased triglycerides and low concentrations of HDL cholesterol, as in our patient history of gestational diabetes. Another category are patients who are receiving antipsychotic therapy. As you know, in some individuals, those can lead to rapid increase in weight and also rise in blood glucose levels. Why is it important? Why does anybody care whether they have prediabetes or not? Well, it turns out that even the microvascular complications of diabetes, which have always been thought of being present only in those people who already had a history of diabetes, are increased. In the diabetes prevention program in the U.S., almost 8% of patients with impaired glucose tolerance already had classic diabetic retinopathy, as compared to about 13% of those who already had newly diagnosed diabetes. So even patients with prediabetes already had presence of diabetic retinopathy, which obviously came as a big surprise. In another study, this was a longitudinal population-based study conducted in Australia. So these are just people off the street, literally. Turns out that there was a very strong relationship between increasing fasting plasma glucose, hemoglobin A1C, and preventive retinopathy, even in so-called normal range. Same thing was seen for microalbuminuria. Again, with increasing fasting plasma glucose concentrations and hemoglobin A1C, even in the so-called normal range, there was a strong association. So those markers for microvascular complications can be seen in some patients with prediabetes, and the obviously better known macrovascular risk or cardiovascular risk in prediabetes is well known. There was a fascinating study done in the nurses, a so-called U.S. nurses study, in which they followed over 117,000 nurses, women, middle-aged, who had no cardiovascular disease, and they followed them for 20 years, between 1976 and 1996. And they found that as compared to patients who did not have diabetes and never developed diabetes over 20 years, those who at screening had diabetes, there was a 5 times increased risk of cardiovascular disease or stroke. So incidence of myocardial infarction and stroke was increased 5-fold if they had diabetes at the entry, compared to those who never developed diabetes over 20 years. But more worrisome, those nurses who developed diabetes over the 20-year follow-up already had increased risk of those MIs and stroke in the period before they developed diabetes. So this is a pretty complex picture, but basically one way to look at it, if women had 15 years or more before the diagnosis of diabetes, their chance of MI or stroke during that pre-diabetes era was almost 2.5 times increased. Now, clearly, the shorter time before diagnosis of diabetes, the higher the relative risk was. But even after all the adjustments were made for a variety of issues such as BMI, smoking, other cardiovascular risk factors, there was a more than threefold increased risk of having myocardial infarction or stroke in the period before those ladies developed diabetes. So again, this is not an innocent state of affairs. One should not wait until patients develop diabetes to start focusing on aggressive management of the cardiovascular risk factors. There was also incidence noted, or association noted, between incident diabetes and hemoglobin A1C. The higher the hemoglobin A1C, the higher the annual diabetes incidence, as it can be seen on the figure from the article by Zhang et al., Diabetes Care. So, for example, at hemoglobin A1C of 6, the annual diabetes incidence was about 5%. But if you went to hemoglobin A1C of 6.5, the annual diabetes incidence doubled. That's where the A1C comes in as a risk factor for diabetes. The other aspect of prediabetes, which has not been well appreciated in many circles, is the risk attendant with elevated postprandial, post-glucose challenge glucose levels, such that patients who might have quote-unquote normal fasting glucose level can have much increased mortality risk from cardiovascular problems if they have a high 2-hour post-challenge glucose. So in the study from DECODE, which was a huge study conducted in Europe, for example, patients with fasting glucose of less than 110 and might have had a ratio in that study of 0.5, but if their 2-hour glucose was over 200, the hazard ratio was over 2, more than quadruple. So patients could have relatively normal fasting glucose, but it was the high post-challenge glucose, which was highly correlated with risk, mortality risk from cardiovascular disease. So again, well before patients have recognized diabetes, they might be marked for both macro and microvascular risk. Of course, the problem we have is that by the time diabetes is diagnosed, at least half of the beta cell function is gone. So in the sort of famous extrapolation of UKPDS data, which was published a while back with Harold Lebovitz as the lead author, they did establish this line in which they traced back when the demise of beta cell function would start, and the estimate was it was about 12 years before diagnosis of diabetes was made. Again, the problem is we're treating patients probably too late. We're missing the critical period of so-called prediabetes during which we could intervene not only with managing the cardiovascular disease risk factors, but also do something about the beta cell function. In a study which was also well publicized in the past with the lead author, Butler, this was an autopsy study, and actually looked at the volume of beta cells to realize that whether you looked at lean individuals or obese individuals, by the time the patients develop diabetes, they had significantly decreased beta cell volume. Obese patients and obese people have significantly larger beta cell volume, but whether they were lean or obese, and patients developed diabetes, there was a significant decline of the beta cell volume. But in the obese individuals in the study, they also looked at those patients with impaired glucose tolerance and impaired fasting glucose, and those also had very significantly reduced beta cell volume. So again, looking at the beta cell function, beta cell volume was also greatly decreased in those people who are about to develop diabetes in the future. Again, showing us that we should be doing something about that problem in advance if we can. What are the factors which can contribute to beta cell dysfunction? There are many, and we already mentioned some of these, such as insulin resistance, the glucose toxicity and lipotoxicity, meaning the dyslipidemia and hypoglycemia themselves are toxic to the beta cell. Clearly, older individuals are more likely to have beta cell dysfunction. We talked about a family history, and there's also evidence for amyloid deposition. One of the things which I'll mention it later on is the issue of the impaired incretin effect, and again, its consequent sort of problem with the beta cell failure. So let's go back to our patient. So we mentioned that she has prediabetes. Now, what are you going to do about it? If we say that all these things are about to happen to her, what can we do? Well, do you encourage lifestyle interventions and refer her to a dietitian? Do you start metformin? Do you start another pharmacological agent? Or do nothing, observe? I mean, she after all is not hurting and she really is not complaining of anything. This was just a routine visit. There's no question that lifestyle interventions and pharmacological agents have been shown to delay onset of diabetes, and they can be or should be employed. The problem we have right now that unfortunately FDA has not approved any pharmacologic agent for treatment of prediabetes, even though the studies indicate that some of these can do it. Physical activity is obviously a well-known factor in improving your glycemic status and hopefully alleviating the risk of type 2 diabetes. In the study, which was published in Diabetology in 2010, they looked at the activity, physical activity, in individuals of different ages and see what the effect was on the hazard of type 2 diabetes. And it showed that clearly the vigorous or moderate intensity of exercise was quite beneficial for patients regardless of the age, whether younger, a bit older, or over 7 years of age. But if you sort of start dissecting it, for those people who are over 70, any type of physical activity reduced risk of type 2 diabetes, including what they call the low intensity. For patients who were less than 70, the physical activity had to be more intense to really see a benefit and reduce the risk of diabetes. But clearly, physical activity is very important in addition to the diet, weight loss, nutrition. Let's go back to the diabetes prevention program. As you know, this was a very large program in the U.S., and it looked at trying to prevent progression to overt diabetes in the high-risk individuals, and there were 3 arms. The 4th arm, which had a TZD, Pioglitazone, was discontinued early on. So the 3 arms, which are shown in this picture from the publication in New England Journal of Medicine in 2002, showed that as compared to placebo, those patients who were enrolled in a lifestyle modification arm, this was an intense lifestyle modification, had a 58% reduction in incidence of diabetes compared to those who were assigned to placebo over 4 years. The patients who were placed on metformin also had a significant reduction in the chance of developing diabetes over 4 years by 31%. But lifestyle modifications were more powerful overall than metformin. But yes, metformin could be thought of as one medication which has been shown to delay the progression to overt diabetes. If one looks at a 10-year follow-up for diabetes prevention program, so as contrasted to the 4-year I showed you before, metformin still had significant reduction years after the patient stopped participating in the program. So there still was a 17% reduction in diabetes incidence after 10 years, which is about half of that accomplished by lifestyle modifications. Lifestyle modifications most powerful. Metformin, however, has been shown to be effective in some of the patients. There are more drugs which have been shown in controlled studies to delay conversion to diabetes, such as Acarbose, the alpha-glucosidase inhibitor. In the so-called STOP-NIDDM study, Acarbose delayed significantly conversion to diabetes, as can be seen in the figure from the article published in 2002. Significant reduction in incident diabetes. Another drug which has been shown in a controlled study to prevent diabetes is Orlistat. And in this figure from Diabetes Care article 2004, it shows that whether patients had impaired glucose tolerance, or if you look at all patients those who were placed on Orlistat as compared to placebo had about 40 to 45% decrease chance of developing diabetes over 208 weeks or 4 years. So we have now metformin, we have Acarbose, we have Orlistat. And then there's TZDs. Both Rosiglitazone and Pioglitazone are powerful agents shown in controlled studies which can prevent onset of diabetes in these high-risk individuals. So, for example, in the DREAM study, which used Rosiglitazone, there was a significant, almost 50% reduction in incident diabetes in those patients who were placed on Rosiglitazone over 4.5 years. Significant decrease. In the study, which was published in 2011 in the New England Journal of Medicine, looking at Pioglitazone, turned out that it was even more powerful. In that particular study, there were 602 patients who were randomized either to 45 milligrams a day of Pioglitazone or placebo. Again, double-blind, placebo-controlled prospective trial of the high-risk individuals. After a mean follow-up of 2.4 years, the annual incidence for developing type 2 diabetes was 2.1% in those assigned to Pioglitazone and 7.6% in those on placebo. So there was a 72% reduction of the risk of conversion from impaired glucose tolerance to type 2 diabetes in those assigned a thiazolidine drug, Pioglitazone. So both Rosiglitazone and Pioglitazone have been shown to be very effective in preventing the onset of diabetes. In a small study of 207 individuals, again with impaired glucose tolerance, a combination approach was tried in Canada. So there were patients who were either on placebo or they were put on combination of two drugs, Rosiglitazone and metformin, 4 milligrams Rosi and 1,000 milligrams a day of metformin, so half of the maximum doses, and it showed that those patients who were placed on the combination of drugs had significant decrease in development of diabetes, and more of those people actually regressed back to normal glucose tolerance. So there was an attempt done at meta-analysis of these approaches to prevention of diabetes. If one looked at the lifestyle intervention, I mentioned diabetes prevention program, but there were also studies done in China, India, Sweden, Finland. They all showed that there is about 50 to 60% reduction of development type 2 diabetes in high-risk individuals by intensive lifestyle modifications. On the pharmacological agent side, I mentioned some, and again, go back, metformin, Acarbose, Orlistat, Rosiglitazone, and Pioglitazone have all been shown in some controlled studies to decrease significantly the chance of developing diabetes. Now, the new kid on the block, as I mentioned before, is the incretin-based therapy. There are no studies yet which specifically looked at the issue of prevention of diabetes in these sort of well-designed studies, but there is obviously belief that these drugs could also join the armamentarium in the future. Why? Well, these agents exert some of the effects on islet beta cells. And again, remember that the demise of beta cells is what brings on the onset of diabetes, and so the protection of the beta cells could be significant. And it is in some short-term incretin-based therapies, it looks like beta cell function is stimulated. Proliferation is increased, differentiation is increased. They also seen more beta cells actually being recruited to the secretory process. So the insulin biosynthesis is increased, insulin content of beta cells increased, and these agents have anti-apoptotic effects. As a result, the beta cell volume is protected. So one could argue that interfering with the progressive beta cell decline could slow down the disease progression and offer another therapeutic approach to patients at high risk. So right now, from what we have, and these are mostly from animal models, only incretin-based therapies and thiazolidine have been shown to actually protect the beta cell function. A hint at what might be happening with incretin-based therapy comes from the studies of liraglutide, which was studied at a higher dose, at 3 milligrams, for obesity management. So we have a human study, and if one looks at the liraglutide obesity trials, one can sort of see what happened to those patients who entered these obesity studies already with either prediabetes or metabolic syndrome. Now, those patients, for those of you who have not followed, have been divided in quite a few arms. These were placebo-controlled trials. Orlistat was serving as the sort of active comparator. And then there were 4 doses of liraglutide, 1.2, 1.8, 2.4, and 3 milligrams a day. And about 1/3 of patients who entered these studies had prediabetes. At the end of 1 year, those patients who were placed on liraglutide, especially the higher doses, had significant reduction in prediabetes, down to about 10% from the 30-ish%. After 2 years, if one looked at the study results, there was at least a 50% reduction in the incidence of prediabetes in those who were placed on the higher dose of liraglutide compared to those who were placed on Orlistat. That was the active comparator. Patients who had metabolic syndrome at the screening were someplace between 40 to 50%. So about half of the patients had metabolic syndrome. Again, just like with prediabetes, after 1 year, those people who were placed on liraglutide had significant reduction to someplace about 17% from about 40%. And at the end of year 2, significant reduction of metabolic syndrome persisted, so that only 16% still had metabolic syndrome. So patients placed on an incretin analog, liraglutide, had, in addition to the weight loss which was shown, also significant reduction in the incidence of prediabetes and metabolic syndrome. So that is sort of the only human trial which could be sort of indirectly tied to using it in management of prediabetes. So what are the recommendations now for prediabetes management? Well, clearly glycemic control is relevant. We talked about the importance of lifestyle modifications and obviously aggressive management of the cardiovascular risk factors such as dyslipidemia, blood pressure, and also low-dose aspirin as far as antiplatelet therapy. So let's just close. Again, how would one manage this patient, his prediabetes? I think that right now, probably the safest recommendation would be to encourage intensive lifestyle interventions, refer to a dietitian, and to engage in hopefully healthy eating and increased physical activity. In addition to that, one could argue that using a metformin at a dose she can tolerate might also be a cost-effective way to encourage management of her prediabetes. So with that, I'd like to close and thank you very much for joining me in this journey, the management of prediabetes, and thank you very much for your attention. Bye-bye.
Thank you so much, Dr. Grunberger, for that comprehensive overview of the diagnosis and management strategies of prediabetes. As Dr. Grunberger emphasized, it has long been recognized that type 2 diabetes is a progressive disorder, the onset of which begins years before its eventual diagnosis. Not surprisingly, both the small and large vessel cardiovascular complications of abnormal carbohydrate metabolism seen in confirmed patients with diabetes already occur prior to its onset. Therefore, both the diagnosis and management strategies of such at-risk individuals must be addressed. The recommendation for when to consider intervention in prediabetes is still being debated. In this regard, I would direct the audience to an article in the October 2014 issue of the journal Diabetes Care, written by 4 prominent diabetologists. It is entitled, We Can Change the Natural History of Type 2 Diabetes. The authors make a strong case for the earlier diagnosis and management of both prediabetes and diabetes. It is evident from Dr. Grunberger's presentation that lifestyle intervention, focusing on both exercise and weight loss, has resulted in delaying or preventing the onset of diabetes in at-risk individuals. Whether or not specific types of diets are more helpful remains unclear and deserving of further study. Moreover, appropriate monitoring and management of lipids and blood pressure also remain key in cardiovascular protection. As well, smoking cessation is a clear must. The addition of low-dose aspirin for primary prevention is also recommended unless there are known contraindications. The American Association of Clinical Endocrinologists strongly recommends that pharmacologic intervention be considered in the management of prediabetes. Metformin has been shown to be effective in delaying the onset or prevention of diabetes, particularly in younger individuals. It remains the first-line drug of choice unless there are the contraindications of renal compromise or severe heart failure. There is a new study now being launched in the United Kingdom with the acronym GLINT, G-L-I-N-T. It is a long-term primary prevention trial in patients with prediabetes designed to examine the efficacy of metformin versus placebo on a macrovascular composite outcome. The study will include close to 13,000 primary care patients who will be followed for 5 to 7 years. Other agents, such as the thiazolidinediones, carbohydrase inhibitors, as well as lipase inhibitors, might also be considered for use in prediabetes. As Dr. Grunberger noted, whether or not the use of incretin-based agents, the GLP-1 agonists, and or the DPP-4 inhibitors fulfill the expectation of preserving islet cell function remains to be addressed in long-term intervention studies as well. Most importantly, it must be emphasized that there are currently no FDA-approved therapies for the prevention or delay of the onset of diabetes. Accordingly, the use of any pharmacologic agent for this indication in prediabetes would be considered off-label. And so, as with much of medicine today, clinical management decisions, although evidence-based by and large, still must be individualized. In closing, on behalf of myself, Dr. George Grunberger, and the Cleveland Clinic, thank you for attending this third session in the fourth season on type 2 diabetes.